to Your Health, Your Choice. I am Dr. Roopnarine, and we're coming to you live from our studios at Olira Heights in San Fernando. On tonight's program, we're going to be discussing diabetes. Back in studio with me tonight is Dr. Brad Sahadeo. Dr. Sahadeo is a family medicine practitioner based in Marabella. As usual tonight, guys, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, let's talk diabetes. Today is Wednesday, April the 19th, 2023, and let's say hello to Dr. Brad Sahadeo. Brad, how are you doing? Welcome to the program. Thank you for coming on to Your Health, Your Choice.
Hi, Dr. Robin. Thanks for having me on the show.
You're very welcome, Brad. Very welcome. Nice to have you again. Brad, it's the former host of this show. Was a big diabetologist, and diabetes was a common discussion point on the show. This is probably about the second or third time since I've taken over that we're discussing diabetes, but it's something that we need to get back to. It's something that people suffer from. There's a lot of interest out there. So I'm hoping that you could tonight just explain some of the concepts so that the audience will get a better appreciation of the illness.
Sure.
So I suppose the first thing, Brad, is that we all know that it's a common problem in Trinidad. It's a big problem. But if you could just start off with giving us the numbers, give us the hard data. How many people in Trinidad suffer from this problem? What's the prevalence worldwide? If you could just give us some hard data on it.
So Dr. Robin, the prevalence of diabetes worldwide is approximately about 10.8%.
Right.
When you put that into figures, it's about 536 million people worldwide.
Right.
Right? As opposed to Trinidad, the prevalence of diabetes in Trinidad is about 12.8% roughly.
Right.
And when you put that into figures, it's about 168,000 people.
Okay.
Yeah. The interesting thing about that, though, that's just the figures that the population who actually diagnosed as diabetes.
Right.
But when we look at the undiagnosed, it's about roughly about 200,000 people.
Okay.
Right? That is total with the undiagnosed plus the diagnosed.
All right. So we have about 100,000 people who are diabetic but not diagnosed.
No.
Okay.
So right, it's about 30,000 people.
30,000 people.
So total.
Okay.
Right? So the total with the diagnosed and the undiagnosed.
All right. So we have about 30,000 people who are suffering from diabetes but haven't been officially diagnosed with diabetes.
Yes, correct.
All right. And we currently have about 100 and how much thousand?
About 168,000 people.
Who have diabetes and in the system.
Yes.
All right. I suppose the other part of it as well is that we all know that diabetes is a multi-system, multi-organ illness, right?
Yes.
But I think sometimes we don't focus on some of the organs that to highlight the effect on some of the organs. One of the big things about people having diabetes and people who having poorly controlled diabetes, one of the biggest fears and one of the biggest things we see in medical practice, we see amputations. People lose toes.
Yes.
And they lose limbs because of diabetes. That's always a very sad thing.
Yes.
If you could just explain to us, how does diabetes affect our feet, and what happens that someone ends up losing a toe or having an amputation done because of diabetes?
Okay, so let's start with the definition of diabetes.
Yeah, go ahead.
So a definition of diabetes is a group of metabolic disorders with hyperglycemia, which is high blood sugar, characterized by a lack of insulin, or either the insulin not working properly, what we call insulin resistance. All right? So when your body has a lot of sugar or in a hyperglycemic state, it tends to damage the nervous system and also the vascular system, right? So you tend to get vascular and nervous damage. So let's take the feet for example. So when you have a lot of sugar in the system, it causes the nerves not to transmit properly. So by doing that, it tends to damage the nerves. All right. So by damaging the nerves, you get conditions like you have tingling in the feet, right? You have loss of sensation to the feet. Also, you have impaired pain perception, right? So you won't be able to feel hot sensation, need a cold sensation. When you walk in, for example, you get nail stick injuries or walking on pebbles, you don't feel it, right? And when you take the vascular component of it, by damaging the vascular component, you don't have the blood supply to the lower limbs. By not having the blood supply, you don't have nutrients. And by not having nutrients and oxygen, these ulcers do not heal. Hence, causing these ulcers in the feet.
How do they get the ulcers?
All right. So when they get the ulcers by pressure.
My principle behind asking these questions is if people out there could not just know that diabetes causes feet problems or causes amputation, to understand how it happens, then they'll be able to at least appreciate self-care.
Yes.
So how does the ulcer come about?
Okay, so let's start with the pathophysiology behind the vascular disease. So what it is when you have a lot of sugar in the system, it interferes with something called nitrous oxide. So by interfering with nitrous oxide, you lose the ability of the blood vessels to not dilate properly. By not dilating properly, it causes vasoconstriction.
Right.
So vasoconstriction, less blood flow to the feet.
Right.
Our next mechanism is that hyperglycemia causes impairment in the fatty acid synthesis. This works synergistically with nitrous oxide. All right. So you don't have the dilation effect. You don't have the ability to smoothen these vessels. And by doing this, you restrict the blood flow to the lower limb. Right. One of the other mechanisms with what high blood sugar does, it releases enzymes that also damages the endothelium, which is the vessels itself.
Okay. And then I suppose that slows down the flow of blood and nutrients, and any kind of injury or kick or cut will tend to open up and not heal properly.
Yes, correct.
And how does it go? How does someone go from, and if you could inform the audience as well, because if we could avoid amputation or a loss of a toe, that's very important. How does something go from an ulcer to having an amputation, and what should someone do when they have an ulcer?
All right. So if you so when you have an ulcer, and of course if it's not healing properly, right, the most important thing is to visit the doctor.
Right.
By visiting the doctor, you can examine your feet properly, and to see if there's any state of any infection or anything, and treat the infection immediately by proper wound care.
Right.
All right. If you know that the infection is not healing properly, it doesn't have the proper blood supply, or you need to seek.
Right.
Yeah.
So the doctor needs to look at it regardless.
Yes, regardless.
Once you have a wound there in your feet.
Have to look at it.
All right. But how do you end up with amputation?
So basically it's non-healing, and the infection spreads up the leg. By spreading up the leg, you need to eliminate the source of infection.
Right.
And hence you lose toes and you could lose.
All right. So I suppose it's as you said, the message is urgent. Getting to see a doctor to avoid amputation.
Yes.
What other illnesses of the feet is caused by diabetes, if there are any other? What other?
All right. So you could get, so we spoke about the nervous system.
Yeah.
By not having proper innervation, right, you could get joint disorders. So there's something called Charcot's joint. It's basically a deformity of the foot, right? By not having proper nerve supply also, you can lose balance, you can lose coordination.
And I suppose in the elderly that's very important.
Very important with falls.
Falls.
Yeah.
And falls would lead to further medical problems.
Of course, yes.
Fractured hips and
fractured hips, and you could get brain hemorrhages and stuff like that.
All right. So I think that was a real good point that you made there, that everybody thinks that that diabetes is just ulcers and so on, but the fact is ulcers, diabetes affects people's balance.
Yes. And
the ability for proprioception, which is to grip the ground and know where you're walking.
Yeah.
And once that is gone, an elderly person could fall and hurt themselves really badly. That's a really good explanation of why we have the amputations and the ulcers. But how does a doctor treat somebody? How would you describe the treatment for an ulcer if somebody comes into you in your feet? Because people do a lot of home remedies as well.
Yeah.
Different doctors might have different takes on how to treat the ulcer. But how would you recommend that you, the doctor, treat the ulcer and the patient treat the ulcer?
Okay. So the patient comes to me.
Yes.
So the patient comes with the ulcer to the foot.
Yeah.
So we start off with the history and examination.
Yeah, of course.
First, right? So based on the history, you could get an idea on the diabetic control.
Yeah.
We could get an idea on their nutrients and stuff like that to assess them properly.
Yes.
Right? When we do the examination, obviously we're going to check their blood pressure, we're going to check their blood sugar, we're going to check their urine, and these sort of things to establish a control with the patient.
Yes.
So the take-home advice of the patient is you need to control your blood sugars.
Yes.
Number one.
Right.
So by controlling your blood sugars, you eliminate or you help it with healing of the infection.
Good point, yeah.
Right? So we established that already.
Yeah.
You need to inspect this foot daily, right? Daily inspection is important. So by inspecting, you could see if the wound is not healing properly, and give proper advice to wound care.
I suppose it's antibiotics. So how do they clean it? Do you recommend that they clean it or don't clean it?
So
it's real basic advice for somebody who's sitting at home with an ulcer right now. They're seeing the doctor or what to do with it until the morning time when they can see a doctor.
Right. So the doctor will give appropriate advice on how to clean the wound.
Right.
Right. Cleaning the wound. We prescribe appropriate antibiotics.
Right.
Yeah. Sometimes if the wound is not healing properly, we could do like a wound swab. We could see exactly what bacteria the wound has and target that with the appropriate antibiotics.
Some people, like, I mean, being a doctor myself in the community, a lot of people come in and say, well, they clean it with methylated spirits, or they put some sort of herbal product, or should the patient, or they put Dettol.
Yeah.
What do you think about all those things?
I think we should not use things like spirits. Spirits tend to be hard on tissues and to damage tissues, which is the alcohol content of it.
Right.
We also don't recommend any herbal stuff on it.
Right.
Right. The medical stuff.
Right. I suppose in Dettols and all that,
No.
So that's what the patient does, just basically wash it and keep it dry.
So use things like saline and stuff to clean wounds. Yeah.
Right. Right, so let's move along.
Yeah.
And another under-explained part in diabetes in terms of the organ damage is how does diabetes affect our brain?
Okay. So we spoke already about the vascular complications and also the nervous system, right? So you could get strokes. That is one. You could also get memory loss, right? And the elderly patients, they tend to get Alzheimer's, tend to get dementia, right?
So I don't want to, when does that happen? After many years or when?
All right.
So I mean, because not every diabetic going to get that.
No, progressive.
Right.
So progressively. So let's say about 10 years down the road with constant hyperglycemia, you could damage the blood vessel, damage the nervous system, and you could put yourself at risk.
All right. So you get strokes.
Strokes, right? We spoke about dementia, so Alzheimer's, all right? And you could also get mood swings because it affects the nervous system. It could affect the frontal lobe and cause mood swings and depression and stuff like that.
Right. And that could sometimes be misdiagnosed.
Yes.
People might think that somebody needs to see a psychiatrist. So fluctuating sugar levels damages the brain structurally.
Yes.
And also emotionally. In terms of how you think. The next big one that people sometimes under-explain as well because of taboo, I suppose, is erectile dysfunction.
Yeah.
Why does diabetes, or can you tell us how diabetes causes erectile dysfunction?
All right. So we go back again to the vascular complications and also the nervous system. So let's start with the vascular component of it. All right. So we spoke about narrowing of the blood vessels secondary to hyperglycemia. Right. So you do have the nitrous oxide effect again, so you don't have the vasodilation, right? So you don't have blood supply to the penis, right?
Yeah.
Also, the nervous supply, so you lose the ability of the autonomic nervous system, right? So you're not sexually aroused, so you will have difficulty getting an erection and also maintaining an erection, which is erectile dysfunction.
Next question is, are these permanent? Are these damages that you describe in the feet, the brain, and in the penis, are they permanent damage that cannot be reversed?
Okay, so that's a good question.
Yeah.
It depends. So let's say we get the patient early, and the patient is in a hyperglycemic state.
Yes.
All right, and we control the blood sugars.
Yes.
They can come back into what we call a normal state.
Right.
Yeah.
All right. But obviously there comes a point where it's irreversible damage. Right, let's move along a little bit. Our next big sort of anxious discussion when it comes to diabetes, at least traditionally in the past, was insulin. A lot of patients I used to tell the doctors, don't put me on insulin, I don't want to be on insulin, or if any community says, so and so on insulin, that means it's sugar real bad.
Yeah.
Right? So there's a lot of anxiety about insulin in society, or used to be. Relieve that anxiety. Tell us about insulin, why is it needed when somebody goes on insulin? And the other part of it is if you could also explain to the audience at home how to use insulin. How is it used? Because some people don't fully understand.
Okay, of course.
Yeah.
All right. So we usually start patients on insulin if the A1C, and an A1C is a blood test that tells us your average blood sugar over a 3-month period.
Yeah.
Right? It's one of the typical blood tests we use where we monitor and follow our patients with diabetes. Right? So once that's over 10%, you usually initiate insulin. right? So that's one of the indications to start insulin.
Is insulin a first-line treatment for diabetes?
No. Okay. Insulin is not the first-line treatment. Right. So there are other medications.
Right, and this is after, if you're using the other medications and the HbA1c
is still over 10%,
you start them on insulin. What types of insulin are there? And how do you know what type of insulin for what type of patient?
Okay, so there are different types of insulin. There's the short-acting insulin, which is basically like a bolus. It's usually used together with meals to drop your blood sugar after meals.
Okay.
All right. There's the long-acting insulin, which is usually given in the morning period, and it gives you a basal release of insulin throughout the day to give you a control of your blood sugar throughout the day. Then there's the intermediate action or the premixed insulin, which we use twice a day. All right. So it's based on the different timing.
Okay. What is the benefit of using insulin versus just using tablets alone? What is the benefit of using insulin? Why is insulin such a big part of diabetes care?
So your pancreas, as you know, has the beta cells, which secretes insulin.
Right.
Your body may not be able to have any insulin again. Right. And you need that insulin to control your blood sugars.
Right.
And it's very important that you control your blood sugars.
Right. How would we know that our body is no longer able to secrete insulin?
So that's a good question. I think it also, when, despite using medication, your blood sugar is not dropping. So that's a proper indication. All right? But despite with diet and exercising, you're not getting proper high control of your blood sugars.
How would you describe to a patient how to use their insulin so that because people be fearful for the first time in their life, they never inject themselves. That is, doctors do that, right?
Yeah.
Nurses inject people. Suddenly it's a sort of self-care. How do you describe that to the patient? How do you start someone insulin? How do you explain to them how to do this safely?
All right. So to administer insulin, first of all, you need to have all your items together, right? So one of them, so you need to have your insulin. So you must read your insulin label properly to make sure you're using the proper insulin. You have your needle, you have your syringe, and you also have like a cleaning swab, like alcohol, to clean the area you're going to inject it. All right? After that, now we're going to identify the site we're going to inject the insulin. So different sites, usually in the abdomen, usually the tricep area, and usually on the anterolateral aspect of the thigh.
Sure, that's
right.
Right.
So,
on the side of the thigh.
Yes. So those are like the fatty areas.
Right.
So we usually inject insulin to those areas.
Right.
Right. So let's take the abdomen for example.
Yeah.
So the abdomen, we can divide the abdomen into 4 quadrants.
Yeah.
1, 2, 3, 4.
Yeah.
All right. And a safe area to inject the abdomen is actually 2 centimeters above the umbilicus.
The belly button.
Yes.
Yeah.
Belly button. All right. So we identify the spot we're going to inject the insulin.
Yeah.
We clean it properly with alcohol. Alcohol that we use our thumb finger, our index finger.
Yes.
Right. We pinch the area we're going to inject.
Yes.
All right. So when you drop the insulin, you inject the area. You release the thumb finger and the index. You inject the area and the insulin into the area. You wait for 5 seconds to get proper absorption. You remove the needle and syringe, and you dispose the needle and the syringe.
Okay. Can anything bad happen from people incorrectly injected insulin?
So if you incorrectly inject it, obviously you can get things like sores, you get infection at the site.
Yeah. So that's things people have to look out for.
Yeah.
Can somebody incorrectly inject insulin?
Yes, you could.
All right.
Yeah. So that's why training is essential.
Right. So it's more the fatty area that
more the fatty areas.
And they look out for any infection.
Yeah.
And the rotation of the sites is to prevent infection.
Of the sites. So for example, if you inject, so we spoke about the 4 quadrants around the belly.
Yeah.
All right. If you inject one area, you usually use a finger.
Yeah.
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 And you inject a finger distance, joint distance from the last injection, and you inject that area with the next dose.
Okay. Dr. Brad, we're just going to take a little break now, all right? So, guys, we're here with Dr. Brad Sahadeo. We're discussing diabetes. Please feel free. I'd just like to invite you at home to send in your questions to us. And it's a big topic. Many people suffer this problem. Just feel free to ask us any question that may be relevant to your condition. And Dr. Brad will do his very best to answer it. All right, guys, so we could start sending any questions from now. Let's deal with them. All right, so we'll see you back in one moment.
everyone. I'm Stacy from Stacy's Kitchen. Check out our new episodes, Season 3 of Stacy's Kitchen at our new time, 5:30 p.m. on Mondays and Wednesdays, right here on ACTN The Voice. I will be whipping you up some flavorful and appetizing dishes. As they say, good food makes a good mood. So guys, stay tuned for this culinary explosion right here on Stacy's Kitchen.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Brad Sahadeo, Dr. Brad, and we're talking about diabetes. So, Brad, we just talked about insulin there and how to use it. Now, tell me, one of the possible problems that people may have with insulin is infections. At the break, you were mentioning something else as well. What other problems you see as a practitioner with insulin or people suffer from?
So, when we advise a patient to take insulin, there are a lot of psychological barriers.
Okay.
All right. So,
yes,
recent data have showed that 1 in 10 patients are actually willing to start insulin.
Actually
willing to start insulin.
Okay.
Right? So if you diagnose 10 people and you decide that 10 people need to go on insulin, at least one person will be willing to go on insulin. Right? So, the psychological barriers. Patients are scared of needles.
That's why we explain that.
So they have anxiety and a fear.
Needle phobia.
Yeah, needle phobia. The next thing is that when you tell patients they need to go on insulin, they think that their condition is actually bad and it's going to get worse. So they lose hope. The next, self-perception. So patients and social stigma. Patients are scared, that's embarrassed that they have to use insulin and tell their friends they have to use insulin. And let's look at a patient occupation. Let's look at a truck driver. Truck driver driving long distances. When this patient is going to get time to inject himself with insulin.
Okay. Excellent points, and I suppose the part of the health practitioner and the allied staff is to alleviate that sort of phobias. I suppose as well the future of innovation in healthcare would lead us to recognize those phobias, which is needle phobias essentially, and social occupational phobias, and overcome them. Is there any way to deliver insulin other than injecting someone and injecting yourself with a needle?
Yes. So
because I assume that is the way forward in insulin innovation.
Yes.
Which you brought up.
There's something, the insulin pumps.
Right.
Right. So the insulin pumps usually develop insulin, gives you insulin through the course of the day.
The artificial pancreas?
Artificial pancreas. Right, so the artificial pancreas is the next option and will be ideal for these patients.
Yeah, I think that's the future.
That is the future of medicine.
That's the future of diabetes care. So it's non-injectable. It injects itself into what? Into the subcutaneous tissues. So you're not doing it. It's real-time monitoring.
Real-time monitoring of the sugar.
Monitoring of the insulin. So you would have to take breaks and go and do it.
Yes.
Good point. Good point. The next question I want to ask is, and people ask this all the time, why is it so possible to treat someone with diabetes and get along and everything works really well? And why is it that some people, it's just really hard to control their blood sugars? Why is that so? Because it's same medications, patients, I mean, they're different, but why is it that some people get great responses and some people don't?
Okay, so I think a lot to do with that is education. Patients are just not educated with respect to diabetes. Less than 10% of patients from recent data have showed that.
Right.
So that's one of the major factors. Other factors, when you give patients medications, let's say give patient oral medication and insulin, have we ever asked this patient if they are able to afford these medications?
Good point. Yeah.
So we're talking about access to medication.
Yeah.
Right? Yeah. We never really look into the social aspect of these things. All right, a patient motivational goals. Take us as doctors, for example. If we are diabetic, we have our clinics to run, we have our family to run. We just don't give diabetes enough time that it deserves. So those are the important points.
And for that's want to trade my 2 cents there. Every patient is an individual.
Yes.
And one formula don't necessarily work for everyone. And the other part of it is more and more I am recognizing that that mental health is a part of getting healthy in everything. And before we used to look at the illness, look at the disease, look at the way we know to treat the illness and treat the disease, tell the patient what to do. That makes very little difference if somebody not ready upstairs, if somebody not in the best mental frame of mind. So I think assessing people's where they are in terms of motivation, where they are in terms of their mental health, where they are in terms of their happiness, will dictate the response that they get to our medication as well. It's really something that we knew from before. Positive thinking, positive attitude leads to a positive result as well. Sometimes in spite of what we give them too, right?
Yeah.
What we give patients. What are the current medications other than insulin that are commonly used in Trinidad for diabetes? And if you explain to the patient how it works. As you said, education is lacking sometimes.
Yeah.
If we give people things, we tell them take this, and they don't actually understand how this works in their body.
Yeah.
If you could explain some of the common ones and how it works in their body to help them.
So one of the most common medication prescribed for diabetes is a class of medication from bigonides, which is metformin. Right? How metformin works? Metformin helps with decreasing the production of glucose from the liver. That's one mechanism. And the next mechanism, it helps with insulin sensitivity. All right? When we look at the next class of medication, we look at the sulfonylureas. So sulfonylureas is a class of medication that helps the beta cells in the pancreas secrete insulin. Right? So having more insulin in the body helps break down the sugar. All right? And one of the other classes of medication is something called the SGLT2 inhibitors, which is the sodium glucose transporters. This works directly on the kidneys. So these sodium glucose transporters actually it holds the glucose. So by inhibiting this action, you tend to expel the glucose through the urine.
Okay. Okay. What is the most common diabetes medication prescribed worldwide? Is it metformin?
Metformin.
Just tell us again how metformin works.
All right. So metformin works by increasing insulin sensitivity.
What does that mean?
Okay. So patients who have insulin resistance. So by eating food continuously with a lot of sugar, a lot of fats, you tend to develop insulin resistance. By having insulin resistance, the metformin works directly at a cellular level to help.
Right. The cells absorb the insulin.
Yes.
Okay. Any side effects of people get metformin is something that people sometimes have problems with. Explain those problems that people get with metformin and how can they be overcome, and I'll leave some of the fears that the people at home may have about metformin. You're a doctor practicing out there. I'm sure you heard a lot of different.
Yes.
And this is your field of interest.
Yes.
Yeah.
So most common side effects with metformin. One, patients tend to get a metallic taste of the mouth. Right? They also feel nauseous. Usually have some vomiting. They usually have abdominal pains, and patients tend to have diarrhea. That's the most common side effects with metformin. All right, how it is we counter these effects? We usually use different brands. Right. So some brands are extended release. So when you take the metformin, it releases slower into the bloodstream. So that is one of the mechanisms. The next mechanism is starting at a very low dose. So by starting at a low dose, the patient will become a little more, will be able to tolerate it gradually.
That's an excellent point, Brad.
Yeah. And our next way to counteract this is to take medication on meals, and these usually help.
Yeah. That's an excellent point. Sometimes people become fearful of the metformin because they get an early side effect, in my experience. But in the UK and stuff, they have lower doses of metformin than the 500 milligram that people use. And sometimes the teaching from some of the doctors over there is that you start at a low dose and then you gradually scale it up. You get patient accustomed to it, and therefore you overcome those sort of side effects.
Yeah, and it fears,
Is metformin taken with meals or not with meals?
Take it with meals.
With meals.
Yeah.
Is it like half an hour before meals, after meals? When's the best time to take it?
Usually taken, if you're taking metformin, usually like a half hour before your meals.
Before the meals.
Yeah.
All right. So therefore, right, so we have a little discussion going. We discussed the medications. We discussed how they work. We discussed some of the common illnesses or some illnesses in the organs that people have that they might not have the knowledge about before, and a certain sort of consequences of it. How can a diabetic who is on medication really know if he's under control? What sort of investigations a diabetic needs to do on a routine basis?
Okay, so my patients, if they come to the office, these are the routine. So the patient come to me. First of all, what we're going to do, we're going to establish a baseline with this patient. So the baseline, what we're going to do is do their height, do their abdominal circumference, do their weight. We're going to work out their BMI. We also do their blood pressure levels. All right. We also do a urine analysis to check for early kidney disease by detecting protein into this urine. And also we do a fasting blood sugar. If this patient has existed in the clinic and we want to know the control of this patient, whether he's controlling his diabetes or not, we do something called an A1C, or glycosylated hemoglobin.
Right.
All right. This is a blood test that actually tells us how the patient has been controlling their blood sugar over a 3-month period. And it's a percentage. Usually, if a diabetic is controlled, this is usually less than 7%. So we know we could establish some control with this patient.
Right. What if a diabetic is greater than 7%? That means they're not controlled?
Each patient is different.
Each patient is different, yeah.
So let's look at the elderly patient who's susceptible to falls and susceptible to injuries from the falls. We usually don't give them a tight control like this.
Good point.
Yeah. So we be a little more lenient on these patients.
Yeah, good point. What are the particular problems that you see in elderly people in terms of too tight control with diabetes?
Okay. With elderly people,
why you need, in other words, sorry to interrupt, I just want to rephrase the question. Why is it important to monitor elderly people more closely than other diabetics?
They can exhibit what we call hypoglycemia.
Hypoglycemia.
Which is low blood sugar. By running low blood sugar, they're susceptible to falls, by being dizzy, having blurred vision, and loss of consciousness.
Yeah, and I suppose to the opposite of that is high blood sugars.
High blood sugar.
In elderly, they get infections very easily.
Yeah.
Urine infections. Urine infections are a very common thing in elderly people. And also, I suppose, any kind of infection, chest infections and everything. High sugars predispose you to infections. That's true. I think Josh have a few questions coming in there. Josh, you could start with the questions, and we'll move the discussion along with that. How should you trim your toenails? That's a real good question, because I suspect what that person is asking is that they want to hurt themselves as a diabetic and cause a cut and then get an infection in the toe that could cause more problems.
This is an excellent question.
Can you answer that?
All right. So this comes along the line of foot care with diabetes.
Yes.
So when you're trimming your toenails, you must trim it straight and not to the corners. You don't want to get infection by harming the edges of the nail.
You trim it straight. What do you mean by that? If you could show us on your thumb, pretend.
Right. So this
you could show me on my thumb.
Okay. So this is it too. We're trimming it straight across, which is straight.
Yeah.
We're not beveling the edges.
Okay.
By beveling the edges, you could damage the nail bed and get infections.
If you cut it across, though, you still have some, I suppose, you wouldn't get any.
You wouldn't get, an ingrown toenail.
Ingrown toenail. Do you recommend people lift it up or anything like that?
No.
How should they clean their toes?
All right, as we on this topic, we'll talk a little bit about the foot care.
Yeah, go ahead.
So, one, when you're cleaning your foot, you clean it with warm water, not hot water. Warm, soapy water, mild soap, twice a day. You dry your feet properly. When you're drying your feet, you dry in between the toes. You don't want moisture between the toes. This is a nidus for infection.
Okay.
Right? Moisture.
Okay.
We talk about trimming the toenails.
Yes.
Also, you make sure you check your feet properly for any ulcers, any sores, any blisters. If, for example, you cannot see the bottom of your feet, you get somebody who is living with you to check it for you, or you use a mirror to check it. Right? You use your proper shoes. You want to wear a shoe that is comfortable, and also not putting pressure on your feet.
Good answer there, Dr. Brad. Any other questions there, Josh? Oh, what type of shoes is best for diabetics? I think you kind of answered that, but if you can ask, so it's just a comfortable shoe?
Yes. So these shoes, first of all, you don't want to wear slippers. You know these slippers with the pieces that go in between the toes. You don't want to kind of not wear those.
You don't want to wear those?
No, those will damage your feet. You want to use clothes.
That's good information, Brad.
Clothes, shoes. You don't want to wear shoes made out of plastic. Plastic tends to provide moisture in the feet. Having moisture is a nidus for infection.
Right.
You want to wear comfortable. You don't want to wear shoes for more than 5 hours for the day. By wearing shoes for more than 5 hours a day, you put unnecessary pressure in the feet, causing ulcers and sores.
Right. I suppose you don't want people walking around in the outside where it might be dirty as well without shoes on.
Without shoes.
That's on that topic. What is some of the recommended vaccinations that a diabetic should have? Let's say an elderly diabetic over 60. They should be up to date with their vaccinations.
Yes.
Why is it important, and what vaccinations should somebody have? What are the vaccines that they need?
So the elderly population, we know that diabetes run the risk of developing infections, especially lung infections.
Yes.
So you want to get vaccinated with your annual influenza vaccine. That is one. And also a pneumococcal vaccine.
Pneumonia vaccine.
Yes. So those are essential to prevent lung infections.
Tetanus as well?
Tetanus, routinely every 10 years.
Routinely every 10 years.
Update the tetanus.
Okay, so those are two main ones, and obviously now a COVID vaccine.
Yeah, COVID vaccine,
Good. Any other questions there, Josh? What activities are best for persons with diabetes in terms of exercise?
So, in certain...
But I suppose you have different age groups and different conditions with diabetes.
So in certain parts of the world, doctors give patients a prescription, an exercise prescription.
Okay.
So the current guidelines, you need to do 150 minutes for the week.
150 minutes a week.
So if you break it down, it's 30 minutes
This is all patients, or all persons, or just diabetics alone?
This is for all patients.
All patients. 150 minutes.
150 minutes for the week. So there's about 30 minutes per day.
For 5 days.
5 days. If the patient can do weightlifting, it's also advisable that you do 2 sessions within the week.
5 days.
Of weightlifting also.
Right. Now, for elderly diabetic, what would you suggest?
So elderly diabetics, first of all, you must get clearance from your doctor. We don't know if this patient has pre-existing heart problems.
Right.
That can put them at risk
of a heart attack.
For heart attack when exercising. So that is critically important. There are other forms of exercising. There's yoga, there's meditation, there's aquatic exercises. Patients who are not able to use a treadmill or walk properly. So, you have to work with your doctor to develop the right.
Why is exercise important for diabetics?
So exercising,
everybody tells everybody go and exercise, but why?
All right. So exercise.
Other than weight loss.
It helps with insulin resistance.
What do you mean by that?
So by decreasing the amount of fat, right? So it uses the extra. So by exercise, you need extra energy.
You use extra energy.
Right. By using extra energy, you use the fat cells, you burn the fat cells to acquire that energy.
Right.
By doing that, you improve your insulin resistance. The insulin works better. You drop your blood sugar, and you get better diabetic control.
Okay, that's a very good answer there as well. We're going to take a second break. All right. So guys, we're here with Dr. Brad Sahadeo discussing diabetes. Feel free to message in your questions so we could at least explain some of the scientific basis of the answers and the information that we gave you. All right. So we'll see you back in one moment.
And when God sends a word, it serves a purpose. It serves a purpose because you serve a purpose. When you hear no, I want you to think next. So if God didn't let me do that, next. Jesus didn't call them to leave their boats. He called them to push out a little. It's a little decision so that I would rely on the grace of God. It's the blessing of both.
Don't forget who you are and whose you are. If it doesn't scare me, it's not big enough. I'll never be the same. Never, never, never. I'll never be the same. In Jesus' name.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're discussing diabetes here with Dr. Brad. Josh, I think we have some questions coming in. We could start with the questions. How can I prevent amputation? We answer that a little bit.
Yeah.
In 3-4 lines, if you could.
That's right. You need to control your blood sugar. Controlling your blood sugar. So we need to prevent, or we need to stop the damage to the nerves and the blood vessels to the lower limb. Right? By doing that, you prevent amputations.
I'm going to ask that question. If somebody came to you and said, let's say a man 40 years old, a doctor 40 years old, and says, Brad, how can I stop myself from getting diabetes? How would you answer that question?
So, first of all,
I'm worried, Brad. My parents have diabetes, but I'm good. But I do ever want to get diabetes. How can you help me never ever get diabetes?
All right, so actually, there's this calculator used in Finland called the Finnish calculator.
The Finnish calculator?
Yeah.
Okay.
So what it does, it puts several factors into it. One of them is the age.
Yeah.
So once you're more than 40 years, you put yourself at risk of developing diabetes. So we call it a non-modifiable risk.
Yes.
Family history has a non-modifiable risk factors.
Yeah.
So let's look at the modifiable ones.
Yeah.
So they talk about the abdominal circumference.
Yeah.
They talk about your BMI. They
Yeah.
talk about the amount of exercise you get in the week.
Yeah.
Talk about your diet.
Yeah.
Right. So all these things, they plug it into the calculator and kind of determine your risk of developing diabetes.
All right. So the actual name of this calculator, I suppose people will go up online and check it out. Is the Finnish calculator risk for diabetes?
Diabetes.
And what it gives you, a percentage risk?
It gives you a score. So if it's more than 12, right, you put a higher risk of developing diabetes.
Right. So this will tell us, yes, what risk we have of diabetes, right?
Yeah.
But my question to you is, the person does not want to get diabetes.
Yeah.
So you
So we spoke start exercising.
Right. So you go through the risk factors.
Right. Go through your risk factors. Exercising. Start eating properly. All right. If you smoke, stop smoking. If you drink alcohol, stop drinking alcohol. And those are the factors.
Yeah. You basically hit the risk factors.
Yeah.
All right, yeah, I suppose that's a reasonable answer as well. Josh, do you have any more questions? Can I remove corns or calluses myself? How would you answer that?
The quick answer to that is no. You shouldn't.
Yeah. The careful answer for that and the safe answer for that is no.
The reason being is you don't want to introduce infection into your foot.
Yeah. Being a diabetic, I would find non-diabetic.
I would say no also.
Yeah.
Right? Because you don't want to be, introducing infection in your foot. And
it's an area that can get really infected very quickly. Feet get infected very, very quickly. So the simple answer is no, you need to see the doctor. And how would you remove it?
Oh, okay. First of all, on the aseptic techniques. First of all, you clean the area properly.
Yeah.
You inspect the area properly. You make sure it's not infected.
Yeah.
And you trim out the area properly, not damaging structures around it. Yeah.
Right. How about those plasters that they sell in the pharmacy and all that? What's your take on those?
And scientifically, I don't know.
You don't know?
Yeah, I don't know if it has any benefit towards any corns or calluses.
Yeah. Next question there, Josh. Does taking insulin mean I have type 1 diabetes? That's a good question that needs explained to this patient, this viewer. Can you explain that?
So let's talk about type 1 diabetes.
Yeah, go ahead.
So type 1 diabetes is basically a genetic disease.
Yes.
So you have a genetic predisposition for autoimmune destruction of the beta cells of the pancreas.
Yes.
So your body cannot produce insulin.
Yes.
So these patients need insulin.
Right.
Right? So let's talk about the type 2 diabetes.
Those are younger patients, from kids.
From kids. Yeah.
So they need insulin because they have a genetic lack of the insulin. All right, go on.
All right, type 2. Let's go to type 2. These patients, over a period of time, their beta cells may be worn out. And they just cannot produce the insulin anymore. So you have a mixed pattern now with type 1 and type 2. And these patients need insulin.
So somebody on insulin does not necessarily mean that they're type 1?
No.
Yeah. Next question there, Josh. Yeah? Is taking insulin painful?
There are ways to prevent. It is a needle going into the skin. You will experience some discomfort.
Yeah.
So there are ways of preventing this. One of the ways of preventing this is icing the area before.
Icing it?
Yes. So by icing the area, you get some numbing effect. And it can actually help with the pain factor.
And if somebody's getting pain while taking insulin, I think they need to review the technique, no?
Yes. Yeah.
Something going wrong there.
Yeah.
It might be that they're using the same area too much.
Yeah.
Not injecting themselves properly.
Not properly, yeah.
Next question there, Josh. Why is my insulin dose higher in the morning and lower in the evening? Very good question. So this person, this viewer, has been prescribed, why is my insulin dose higher in the morning and lower in the evening? All right. So they've been prescribed insulin by the doctor. And the dose is higher in the morning and lower in the evening. And they want to know why. Why is that so?
Okay, so most likely, I'm thinking this patient is probably on a mixed insulin or probably on 70-30 insulin.
Okay.
Right? So the reason why the insulin is high in the morning is to compensate for the meals during the course of the day.
Okay.
So you need to compensate for your breakfast, lunch, dinner.
Right.
Yeah.
Let's explain that again. Sorry, Brad. I think I was lost a little bit there.
Okay.
Mixed insulin. Explain what mixed insulin is, the viewer, and 70-30, and why it is that the morning dose is higher than the evening dose again.
Okay, so the mix is a mixture of the short acting and also the long acting.
Right.
Right? So, okay, so why it is high in the morning?
Right.
The reason why it's high in the morning is to compensate for the meals during the course of the day.
Right, so it's a mix so that later on in the day,
yes,
you'll have enough insulin for when you're taking sugars.
Right, and the reason why you take a lower dose of the night is because you only have in one meal, which is a dinner.
Right, and you don't want somebody dropping low in the night.
Because they get hypoglycemia.
That makes a lot of logical sense there. Yeah. The next question, Deborah. What is the effect of Corelli on diabetes, and should Corelli be a regular in one's diet? That's a good question.
Yeah.
Can you explain that?
I mean, evidence-based, I never came across anything, honestly, with the benefits of Corelli towards diabetes.
Right.
But vegetables on the whole.
Right. And green
vegetables on the whole is beneficial to a patient with diabetes.
How is green vegetables beneficial to someone with diabetes?
One, because of the calorie count.
The calorie count?
Yeah, it's a very low calorie count and offer a lot of nutrients and vitamins towards the body, which is beneficial to patients with diabetes. Right? It doesn't cause insulin spikes, and hence it doesn't raise your blood sugar.
Talking about that, what diet would you recommend for diabetics? Bear in mind the local context.
The local content.
Yeah. Local context. Yeah.
Yeah. So let's look at the Caribbean plate. Let's take a context where we go into the market.
Yeah.
Right. I live in Marble. I go to Marble market.
Yeah.
So you go into the market. You see a vegetable stall. Right. Yes. We must know the different type of food types.
Yeah.
Right. So there's your staples or your carbohydrates. You must know your leafy vegetables.
Yeah.
We must know your protein.
Yeah.
Right. So there's the three major components.
Yeah.
All right. So your staples. Let's look at the ground provisions. Look at yam, cassava, eddos, tashine.
So these are allowed. These are what you recommend.
Yes.
But
everything is portion size.
Okay.
So actually, the amount of carbohydrates you need in that is the front fist. So if you measure this area here, this is actually the amount of carbs you need in that.
Right.
If you turn your fist this way, and you measure this area here, this is the amount of green leafy vegetables you need in a diet. Right?
Okay.
If you look at open the palm of your hand, and we circle this area, this is the amount of protein you need in your diet. That's like your fish and your chicken. Right? And that's your portion size.
Right. So you're saying yam, dasheen,
And those things are
green fig,
locally available.
cassava.
Green fig, cassava.
Fine for diabetics.
Yes.
And then you pack up with
Portion size is important.
not a huge amount.
Not a huge amount.
And then you pack up with your green leafy vegetables.
Green leafy, yeah.
And then you meet afterwards. Is there any foods that is bad for diabetics other than the obvious cakes and sugars and so on?
Right, so we're looking at that food that will cause insulin spikes.
Yeah.
Right, we look at the simple carbohydrates.
Okay, of course, yes.
Yeah, so we look at rice,
Yeah.
flour with all the whole wheat and the minerals and stuff. Or we look at, you said like sugary drinks and soft drinks, all these things causes insulin spikes.
Okay.
Yeah, pasta and these things.
All right. We have another question there, Josh. My bottle of insulin will expire next month. Can I still use it or do I have to throw it away? It's not expired.
It's not expired, so I
It's
guess
good to go.
it's safe to use.
Yeah. Next question there, Josh. Does injecting insulin to the stomach cause additional fat to accumulate there?
Right, so that's an excellent question. So when we spoke about administering insulin, all right, we talk about rotational sites. So you don't want it to be injected in the same area consistently, right? By injecting insulin to the area, you can get fat deposition under the area, accumulation of fat. So that is correct.
It can't get that.
Yeah, that's one of the side effects.
That's why you move it around.
That's why you move it around.
All right, I think that's it for the questions for the time being. But moving forward, insulin, sticking in cells, needles, people don't want to do it. They find it hard, right? It's painful. So you're saying about the insulin pump might be the future that we'll see in the future. That's future developments in insulin. Similarly, checking your sugar is sometimes people have to stick themselves. They have to stick themselves several times during that day. It's painful. It's annoying blood. What is the future of glucose monitoring in the world right now? Where would we be in a year or 2 years or 5 years from now in terms of monitoring sugars? Is it always going to be sticking with the finger with a little lancet?
So the FDA has approved, right, some continuous glucose monitors.
Continuous glucose monitors, yeah.
Unfortunately, these devices are still minimally invasive. So these are implantable devices. Usually, we put the implantable device on the upper arm, and there's a small needle inserted, right, into the subcutaneous tissue, right? And what this does, it kind of measures the glucose in the interstitial fluid. The interstitial fluid is the fluid between the cells. These continuous glucose monitors need to be changed approximately every 7 days.
Okay.
And what this does, it tells and it's an app, a smart app, and it tells you the sugars throughout the day.
Right.
Right. So this is actually FDA approved.
Right.
So let's look at some of the other methods that is on its way and hopefully gets approved. So one of them is the mechanism of optical spectroscopy. What this does, this uses light. So it's like a finger device, right? It uses light, and it actually, the amount of light absorbed is an algorithm it works out and tells you your sugar levels.
Okay. No sticking.
No sticking at all.
Right.
One of the other methods is what we call photoacoustic spectroscopy. So it's a device. One of the devices I saw is that the earlobe device. It sends ultrasonic waves. Based on the ultrasonic waves, it creates energy within the cells, builds up thermal energy, and this sends a signal back telling you the amount of sugar you have in your system or glucose.
Okay. So those are three future,
Yeah.
but they're actually out there already?
Yeah.
Worldwide?
Yeah.
Just as we have another question there, Josh, go ahead. Does insomnia affect or cause diabetes? How does that, meaning poor sleeping habit, poor sleep?
So poor sleep. If you don't have a proper sleep, you will release stress hormones. Stress hormones like adrenaline and the corticosteroids. These have negative effects on your blood sugar levels. These cause spikes in your blood sugar levels.
Poor sleep.
Poor sleep.
Okay, and I suppose once you moderate that effect of poor sleep, then your sugar levels will go down.
Well, it will help. Definitely help with controlling your blood sugars. That is one of the mechanisms to control your sugar proper sleep.
Okay, well there, viewer, you got your answer. Dr. Brad, we've come to the end of the show. It was really, really engaging, exciting. Yeah, all right, yeah, put it on. Sorry. We're just going to take a final question. Can't leave the viewer hanging. Go ahead. Oh, okay. Great program. I watch your TikTok videos, Dr. Brad. All right, I think that's probably a wife for your mom. Thanks. Yeah, Dr. Brad has been putting out a few videos on TikTok with diabetes education. I've watched a few myself, and I must say they're really excellent. I like I suppose TikTok is very short.
Yeah.
But I like that you just hit the questions that people want to know. Yeah, you know what I mean?
Just engage the audience.
Engage, yeah. So Brad, thanks a lot. It was really great having you on tonight. All right. So guys, thanks to Dr. Brad again, and thank you at home for joining in the conversation, sending your questions, and keeping our educational programs going. All right, guys. So have a pleasant evening tonight. Take care. Good night. God bless each and every one of you, and we'll see you again next week. Take care now, guys. Thanks, Brad.